Okay, so picture this. Your heart is this amazing machine, right?
Hmm.
But it has these four delicate valves, and sometimes those valves malfunction,
Yeah.
and they cause blood to flow in the wrong direction.
Right.
That's valvular heart disease.
Yeah,
It's subtle, but it can have a really big impact, and millions of people live with it.
that's right.
And today we're going to go deep on it,
Absolutely.
understanding how those valves work, what can go wrong, and how doctors actually figure all this out.
It's fascinating stuff.
Right. And of course, huge thanks to London Heartbeat's Z Academy
Hmm.
for giving us this awesome medical material.
They are a fantastic resource.
Be sure to check them out on Facebook, Instagram, Spotify, and YouTube for more dives into cardiology.
Really interesting stuff.
So let's jump in.
Yeah.
What's really amazing to me is how doctors can start with just the patient's symptoms, which can be super vague,
Hmm.
and then work backward to figure out what's going on with the valves.
Yeah, it is. It's like they're translating a language,
Hmm.
from I'm feeling tired all the time to, oh, maybe my aortic valve's leaking. Yeah.
Exactly. It's like decoding a message.
What it is.
Now, one of the common complaints, of course, is shortness of breath, and that could be from a ton of things.
Right.
But when we're talking about valves, it often means there's a problem with blood flow.
Yes.
And if you have shortness of breath, especially at night, doctors often think about increased pressure in the pulmonary veins,
That's right.
which can point to a specific valve issue.
Yeah.
Okay, so let's start with a really common issue, mitral stenosis,
Okay.
a narrowing of that mitral valve.
Right.
What's actually going on in the heart when that happens?
So think of it this way. The mitral valve, it's like a doorway between two chambers. The left atrium, where blood comes in from the lungs,
Right.
and the left ventricle, which is the heart's main pumping chamber.
Okay.
And when that door narrows, it's harder for blood to get through, and that creates a pressure buildup
Oh, I see.
in the left atrium.
Okay.
And then that pressure backs up into the lungs, and that's what can cause that shortness of breath.
So it's like trying to squeeze through a crowded doorway. It's like everyone's trying to get through at once.
Exactly.
And this can lead to something called pulmonary hypertension.
Yes.
How are those two things connected?
It's like a chain reaction. There's this theory called the Jordan theory, and it basically explains how the pressure in those pulmonary veins triggers this whole domino effect.
Okay, walk me through it.
Okay, so first the pressure causes fluid to leak into your lung tissues.
Okay.
And then the walls of those tiny air sacs in your lungs, they start to thicken, which makes it harder to breathe.
Got it.
Your body senses this low oxygen,
Right.
and it tries to fix it by constricting the blood vessels in the lungs.
Oh, wow.
And it starts in the lower lobes and then spreads.
Okay.
And that ultimately leads to pulmonary hypertension.
So the body's actually making it worse.
It's kind of like the body's fix is actually making the problem worse.
That's amazing and scary how it can snowball.
It is.
So how do doctors even know if someone has mitral stenosis?
Well, it's not just about listening to the heartbeat. It's listening carefully,
Okay.
observation, and even some calculations.
Calculations, math for heart murmurs.
In a sense, so the first heart sound, we call it S1.
Okay.
It's louder in mitral stenosis because it takes more force to close that narrowed valve.
Oh, I see.
Then doctors use something called the Walls Index,
Okay.
which looks at the time between the electrical signal from your heart, that Q wave on an EKG, to that S1 sound,
Got it.
and then the time between the aortic valve closing and the mitral valve opening.
Wait, there's a sound when the mitral valve opens.
Yeah, there is. You get an opening snap when that restricted mitral valve finally opens.
Wow.
And the shorter the time between the aortic valve closing and that snap, the more severe the stenosis is.
Oh, so it's like the timing is everything.
Exactly. The Wells Index helps determine if that opening is dangerously restricted.
It's like a code.
Right. The timing of those sounds reveals the severity.
And what about the murmur itself?
Usually it's low-pitch rumbling. It's heard best at the apex of the heart, especially if you're lying on your left side.
Oh.
The longer the murmur, the tighter the stenosis.
So it's like the heart is whispering its secrets.
It is, and doctors have learned to listen.
But I read that the loudness of the murmur isn't always reliable.
True. It can be affected by other things like other heart conditions or even your body type.
Okay.
It's really about looking at all the factors. The patient's symptoms, the length of that murmur, the Wells Index, and if there's pulmonary hypertension.
So you're taking in the whole patient, the whole picture.
You've got it.
Okay, so let's stick with pulmonary hypertension for a sec.
Mm.
Are there specific signs that point to how severe it is?
Well, think about it. When pulmonary hypertension gets worse, the pressure in your heart increases, and that makes your valves work harder.
Okay.
So a prominent wave in your jugular venous pulse,
Right.
that's the pulse in your neck, can be a sign of severe pulmonary hypertension.
Wow.
Because the right atrium, one of the chambers in your heart, it has to work harder to push blood against that resistance.
So looking at the neck veins gives us clues about what's happening in the lungs.
Exactly. It reflects the pressure in the right side of the heart,
Okay.
which is directly affected by pulmonary hypertension. You might also see a palpable P2, that's the second heart sound associated with the closure of the pulmonary valve.
Right.
You can feel it as a vibration because it's closing with more force.
Yeah.
You can also have a palpable pulsation in the pulmonary artery itself, a very loud P2.
Right.
A distinct ejection click sound, and you can feel that the right ventricle is enlarged.
Okay.
And there can be a loud murmur associated with tricuspid regurgitation, which is a leaky tricuspid valve.
So many things to look at.
Yeah.
But how do you know if the tricuspid regurgitation is a direct result of mitral stenosis or if it's a whole separate thing?
That's a great question. You need to differentiate between two types, hypertensive and organic tricuspid regurgitation.
Okay, break those down for me.
So hypertensive tricuspid regurgitation, that's caused by that high pressure in the pulmonary circulation,
Right.
often as a result of mitral stenosis.
Okay.
It's a secondary issue caused by that primary valve problem.
Like-
Organic tricuspid regurgitation, on the other hand, that's due to a problem with the tricuspid valve itself,
Okay.
such as damage from things like rheumatic fever or endocarditis.
Right.
So to tell them apart, you have to think about the sound of the murmur and what's happening in those neck veins.
Okay.
Hypertensive tricuspid regurgitation usually has a murmur that lasts throughout the entire contraction phase of your heartbeat,
Okay.
and it's high-pitched.
Got it.
And the jugular venous pulse will show a rapid Y descent,
Right.
reflecting the ventricle quickly filling from the atrium,
Okay.
and you'll typically see that enlarged right ventricle.
Okay, so that's hypertensive. What about organic?
So the murmur might be shorter and not as loud. It's
Okay.
usually lower pitched.
Got it.
You might also see a slow Y descent in the jugular venous pulse, indicating tricuspid stenosis is also present.
Okay.
And if the right ventricle is enlarged, it may be more forceful, but without that longer duration you see in hypertensive TR.
Wow. So many subtle differences.
It is, but it helps doctors tell them apart.
Fascinating. Now, does mitral stenosis ever affect the left ventricle, even though the initial problem is with that mitral valve?
It can for a few reasons.
Okay.
So first, imagine the left ventricle isn't getting its usual workout because there's less blood flow.
Right.
It adapts by becoming smaller and stiffer,
Oh, interesting.
which means the heart's not pumping as effectively.
So it shrinks because it's not getting enough blood.
Kind of, yeah. But it's not just that restricted blood flow.
Okay.
The rheumatic fever that often causes mitral stenosis can also cause inflammation and scarring of the heart muscle itself.
Oh, so the disease process itself can damage the muscle.
Exactly. Think of
Yeah.
it like this. The scarring and thickening from the mitral stenosis can actually restrict the movement of the heart muscle near that valve,
Okay.
reducing the left ventricle's ability to fill properly.
So it's like physically tugging on the muscle.
Precisely. And when mitral stenosis causes pulmonary hypertension, the right ventricle gets overloaded. And that can throw off the synchronized movement between the left and right ventricles, further impacting the left ventricle's function.
It's like it's all connected.
Is.
Then you have atrial fibrillation,
Right.
that irregular heart rhythm.
Exactly. And that can lead to a weakened heart muscle over time because of that rapid heart rate.
Okay.
So you can see there are many factors that can contribute to problems in the left ventricle with mitral stenosis.
The domino effect.
It is. The valve, the heart muscle, and the rhythm all play a role.
Now, mitral stenosis can also cause hemoptysis, which is coughing up blood.
Yeah.
What's the connection there?
It's usually because of that increased pressure in those pulmonary veins.
Okay.
Imagine those tiny blood vessels in your lungs rupturing because of that high pressure.
Oh, no.
That's what causes the bleeding.
Yeah.
It can range from blood-streaked sputum to more serious bleeding.
So the color and consistency of the sputum can kind of help you figure out what's going on.
Yeah, pink frothy sputum, that's a sign of pulmonary edema,
Right.
a severe buildup of fluid in the lungs.
Oh, yeah.
And that can happen in advanced heart failure.
Got it.
Blood-stained sputum is more common with that paroxysmal nocturnal dyspnea, that shortness of breath we talked about.
Right.
And you mentioned blood clots.
Yeah.
So blood clots forming in the heart, particularly in the right atrial appendage, are more likely in patients with mitral stenosis who also have congestive heart failure and atrial fibrillation.
Really?
And those clots can travel to the lungs, causing blockage and bleeding.
Oh, wow.
And then there's pulmonary apoplexy, which is a rare condition.
Okay.
Sudden and profuse bright red bleeding.
Oh, no.
It's scary, but thankfully rare.
So many issues can come from one valve problem.
It shows you why early diagnosis and treatment are so important.
Definitely. Now back to those heart sounds. We know a loud S1 is a clue in mitral stenosis,
Yeah.
but what else can influence how loud that is?
Well, think about the valve itself. A thicker or calcified valve tends to produce a louder S1.
Okay.
But the position of the leaflets also matters.
Right.
If they're widely separated at the time of closure, the sound will be softer. It's all about the timing.
So it's more nuanced than just the thickness.
It is a faster heart rate or a shorter PR interval on the electrocardiogram
Right.
that measures the electrical activity of your heart will generally make a louder S1.
Okay.
Also, a stronger contraction of the heart muscle will lead to a louder S1.
So many factors.
Are there situations where S1 is loud even without mitral stenosis?
I would think so.
Absolutely. For instance, conditions like sinus tachycardia,
Right.
where your heart beats really fast, or a short PR interval,
Oh, yeah.
which indicates a fast electrical pathway in your heart, can cause a louder S1.
Interesting.
Anything that increases blood flow across the mitral valve can cause this.
Right.
More blood moving through means a more forceful closure
Makes sense.
and a louder sound. Now, can S1 be soft even with mitral stenosis?
I would imagine so.
Yes. If the mitral valve is heavily calcified, it can become less mobile.
Right.
So the leaflets might be thick, but they don't snap shut forcefully. So you get a softer S1.
So thick doesn't always mean loud.
Exactly. Another reason is if there's also mitral regurgitation.
Right.
That leaking of blood back into the left atrium actually reduces the pressure difference across the valve when it closes,
Oh, I see.
making S1 softer.
So the leaks takes the pressure off.
Precisely. And other valve issues can mask that loud S1 you'd expect with mitral stenosis, like aortic regurgitation,
Right.
where blood leaks back into the heart.
Okay.
Even the patient's anatomy can play a role.
Wow.
If the right ventricle is really enlarged, it can shift the heart's position,
Interesting.
muffling those sounds from the mitral valve.
It's like it gets in the way.
It does.
Yeah.
And of course, things like obesity or lung disease can muffle those heart sounds too.
Right. Makes sense.
Yeah.
So it's not just yes or no.
Exactly.
Okay, let's talk about that opening snap again. Can you explain a little more about what causes that sound and why it's so important in diagnosing mitral stenosis?
It's all about the pressure behind that valve. That moment when the mitral valve leaflets are fully stretched open into the left ventricle. That sudden tensing of those leaflets.
And the timing is key.
It is. The higher the pressure in the left atrium, the earlier that mitral valve opens closer to the second heart sound.
I see.
So a short A2OS interval.
Right.
The time between the aortic valve closing and the opening snap
Okay.
indicates a high left atrial pressure, meaning the stenosis is more severe.
It's like it's rushing to happen
That's a great way to picture it.
because the pressure behind it is so high.
Exactly. And doctors quantify this timing using the Wells index.
Okay.
It takes into account the time it takes for the electrical impulse to travel from the top to the bottom chambers of your heart,
I got it.
subtracting that A2OS interval.
So it's a formula that uses electrical and acoustic information.
Exactly. And research shows that a Wells index greater than 2 units
Okay.
means that mitral valve opening is dangerously restricted. It's a powerful tool for estimating the severity.
Listening carefully is so important.
It is. Now, we've talked about that rumbling mitral diastolic murmur.
Right.
Are there any nuances to that murmur that can help doctors tell it apart from murmurs caused by other conditions?
I'm sure there are.
There are. Location is key. It's best heard in the pulmonary area,
Okay.
the second intercostal space to the left of the sternum.
Got it.
And it's localized. It doesn't radiate widely.
Right.
That helps distinguish it from the murmur of aortic regurgitation,
Right.
which is often heard along the left sternal border and can radiate to the heart's apex.
Right.
You can also feel the mitral stenosis murmur as a vibration,
Oh, wow.
a thrill over the pulmonary area. That's not usually the case with aortic regurgitation.
So you're not just listening, you're feeling too.
Exactly. What else? The response to breathing is another clue.
Okay.
The split between the two components of the second heart sound A2 and P2 that widens when you breathe in with mitral stenosis.
Okay.
This doesn't typically happen with aortic regurgitation.
So the timing changes with breathing.
It does. And standing up doesn't change the mitral stenosis murmur much.
Okay.
Aortic regurgitation often becomes louder when you stand because more blood returns to the heart, increasing the volume leaking back through that valve.
So many subtle differences.
There are.
But even with all these clues,
Mm-hmm.
I know that the intensity of the murmur doesn't always match the severity of the stenosis.
That's true. If your heart isn't pumping enough blood, like In severe heart failure, the murmur might be quieter because there's simply less blood to make the noise.
Okay.
Atrial fibrillation can also affect the intensity because that irregular rhythm reduces the pressure difference across the valve, leading to a softer murmur.
So it masks the severity.
Yeah, kind of. Other conditions like aortic stenosis or aortic regurgitation can influence the murmur as well.
Okay.
And extensively calcified valves might not vibrate as much, resulting in a softer murmur.
So a thick, stiff valve muffles the sound.
Exactly. What other clinical signs can point to severe mitral stenosis besides the murmur? Well, think about it. If the stenosis is severe, your body is going to be struggling, and that shows up in a few ways.
Right.
You'll have shortness of breath, fatigue, and fainting.
Okay.
A long, high-pitched mitral diastolic murmur
Right.
and a short A-to-OS interval are also strong indicators.
Got it.
And then there's severe pulmonary hypertension with its own constellation of signs.
So it's not just the heart, it's how the whole body is reacting.
Exactly. And you might even see a mitral facies.
Okay.
With flushed cheeks and bluish lips
Wow.
in patients with long-standing untreated mitral stenosis.
Ugh.
It's the body trying to compensate for that reduced blood flow and oxygenation.
So even their appearance can offer clues.
It can. Now, mitral diastolic murmurs can be caused by things other than rheumatic mitral stenosis.
Right.
Anything obstructing blood flow into the left ventricle can create a similar sounding murmur.
So you need to figure out the obstruction, not just the sound.
Precisely. So a left atrial myxoma,
Okay.
which is a tumor where there's a membrane dividing the left atrium, can both cause a similar murmur.
Wow. So many things.
There are. And conditions that increase flow across the mitral valve can create a diastolic murmur even without an obstruction.
So it could be too much blood flowing through.
Exactly, like a rushing river creating rapids.
Interesting.
And in severe mitral regurgitation, where blood leaks back into the left atrium, you can get a similar murmur.
Okay.
Congenital heart defects can redirect extra blood through the mitral valve,
Right.
creating that murmur. Even a heart pumping faster and harder than usual can create a similar sound.
So many possibilities.
There are. It's not a simple diagnosis.
Right.
You need a thorough history,
Mhm.
a physical exam, and often further testing to figure out the cause.
Wow, this is a real deep dive.
It is. It is. And speaking of complexities, let's shift gears and discuss mitral regurgitation, another common valve issue.
Okay.
So unlike mitral stenosis, where the valve's narrowed in mitral regurgitation, the valve doesn't close properly, causing blood to leak back into the left atrium.
So it's leaky.
Yeah,
Yeah.
exactly.
Okay, so what causes this leaking?
Several things. Rheumatic heart disease, where the valve leaflets become thick and scarred, preventing them from sealing tightly.
Right.
Hardening and thickening of the ring around the mitral valve,
Right.
called annular calcification,
Got it.
that can distort the valve and lead to regurgitation. Endocarditis, an infection of the heart valves, can also damage the leaflets and cause leakage.
So the valve is damaged or deformed.
Yes, preventing it from doing its job.
Okay, are there other reasons why this might happen?
Yes, sometimes the leaflets are fine, but something's interfering with their closure.
Okay.
We call that dynamic mitral regurgitation.
Dynamic mitral regurgitation. Interesting. What are some examples?
Well, think about mitral valve prolapse.
Okay,
One or both leaflets bulge back into the left atrium, causing that leak.
got it.
Dilated cardiomyopathy, where the heart muscle's weak and the chambers are enlarged, can also lead to mitral regurgitation.
Right.
It's almost as if the enlarged ventricle is stretching the valve, preventing the leaflets from meeting properly.
This is being pulled apart.
Exactly. What else ischemia or lack of blood flow to the heart muscle can cause problems with the papillary muscles?
Okay.
Those tiny muscles that anchor the mitral valve leaflets?
So the support system is compromised.
Exactly.
Does it matter how much blood is leaking back?
It does. The clinical impact of mitral regurgitation depends on how much blood's leaking back into that left atrium and how quickly the condition develops.
So a small gradual leak is not as big of a deal as a large sudden leak.
That's right. The heart can adapt to gradual changes. If the mitral regurgitation develops slowly, the left ventricle can adjust,
Okay.
gradually enlarging and thickening to accommodate that extra blood volume.
So it's remodeling.
It is, and that enlargement helps maintain forward blood flow and prevents a sudden pressure rise in the left atrium and lungs.
But what if the leak develops quickly?
That's a problem. Imagine a sudden rupture of the chordae tendineae,
Okay.
one of those cords anchoring the valve leaflets. The left atrium and lungs might not have time to adapt. The pressure increases rapidly. And you can see symptoms like shortness of breath and even pulmonary edema.
So the suddenness is the problem.
Exactly. What factors influence how much blood leaks back?
That's a good question.
Well, it's more than just the size of the leak. The pressure difference between the left ventricle and the left atrium plays a role.
Right.
The higher the pressure, the greater the volume of blood flowing back.
Makes sense.
The duration of the contraction phase of the heart systole.
Okay.
That also matters.
How so?
The longer the systole, the more time there is for blood to leak back.
Yeah.
It's like a leaky faucet.
I like that.
The bigger the hole, the higher the pressure, and the longer you leave it on, the more water you lose.
Perfect analogy.
Right.
I was reading, though, that the volume overload in mitral regurgitation is less severe than in aortic regurgitation.
Interesting.
Even if the leak and pressure gradient are larger in mitral regurgitation? That seems counterintuitive.
Yeah, great observation. It comes down to timing.
Okay.
Mitral regurgitation leakage happens during systole, which is a shorter period compared to diastole, that relaxation phase.
Okay.
In aortic regurgitation, the leakage happens during diastole, which is a longer period.
So even with a bigger leak, it's happening for a shorter time.
Exactly. Picture a bucket with a hole. You'll lose less water if you dip it in and out quickly than if you leave it submerged for longer, even if the hole's smaller.
Makes sense.
It does.
Okay, so what clues might a doctor pick up on a physical exam that point to mitral regurgitation?
Well, one of the first things they might notice is a hyperdynamic apex.
Hyperdynamic apex. What's that?
It means the point where the heartbeat is felt most strongly
Okay.
is more forceful than usual.
So a stronger thumb.
Exactly. It reflects that left ventricle working harder to pump out that extra volume of blood.
Oh,
If the regurgitation is severe, they might even feel a vibration at the apex.
wow.
A systolic thrill, which indicates turbulent blood flow.
Okay.
Then sometimes you might feel a diastolic thrill, but that's more common if mitral stenosis is also present.
So many things to feel.
Yeah. It's a puzzle piecing it all together.
Right.
A late systolic pulsation in the left atrium felt in the area next to the sternum is another clue.
Okay.
This indicates the left atrium is overloaded with blood during systole because of that backflow.
It's getting hit with extra volume.
Exactly.
Fascinating.
It is. What about the heart sounds themselves?
The first heart sound, S1, is usually soft in mitral regurgitation.
Really? I would think it would be louder if it's leaking.
It seems counterintuitive, right?
Yeah.
But remember, those leaflets might be defective.
Right.
So they don't snap shut as forcefully.
Okay.
Also, the leakage often begins early in systole, even before the ventricle is fully contracting,
Right.
which can muffle the S1 sound.
Got it.
And then there's that loud systolic murmur that often accompanies mitral regurgitation,
Right.
which can mask the S1 sound entirely.
So it drowns it out.
It does. What about the second heart sound, S2?
Does that tell us anything? It can. In severe mitral regurgitation, S2 is often widely and variably split. Remember, S2 has two components: A2, the aortic valve closing, and P2, the pulmonary valve closing.
Right.
Now, when the mitral valve leaks severely, the left ventricle empties more easily because a lot of blood escapes back into that left atrium.
Got it.
This makes the aortic valve close earlier,
Right.
leading to a wider separation between A2 and P2.
Okay.
And the wider that split, the more severe the regurgitation.
So you're listening for the split and how wide it is.
Exactly. And if the P2 sounds louder,
Okay.
that could indicate pulmonary hypertension,
Right.
which can be a complication of mitral regurgitation.
Okay, so subtle differences again.
Yes.
Now, what about the other heart sounds, S3 and S4?
Yeah.
Do those tell us anything about mitral regurgitation?
They can. So S3,
Okay.
a low-frequency sound heard early in diastole.
Right.
It tells us about the volume of blood filling that left ventricle. Think of it as a sloshing sound as the ventricle rapidly fills.
So rapid filling, we might hear S3.
Exactly. And if the mitral regurgitation is caused by structural abnormalities of the valve, an S3 usually means the leak is significant.
Okay.
But if the regurgitation is caused by problems with the heart muscle itself, the meaning of S3 changes.
Interesting.
It might signal a stiff ventricle, not necessarily a severe leak.
So the meaning changes.
It does, and crucially, if you hear an S3, it essentially rules out significant mitral stenosis.
Oh, that's helpful.
Right. This is because with mitral stenosis, the blood flow into the ventricle is restricted. There's no sudden rush of volume to create that S3 sound.
So it can tell you what's there and what's not there.
It can.
When is S3 most likely to be present with mitral regurgitation?
You're most likely to hear it when there's a large backflow of blood, but the left ventricle is still functioning well.
Oh.
Or when the left ventricle is damaged and isn't pumping efficiently.
So a high-performing ventricle with a big leak or a struggling ventricle.
Yeah.
Now, what about that opening snap we talked about with mitral stenosis? Can you hear that in mitral regurgitation too?
You might. It might be present if the mitral valve leaflets are thickened and stiff.
Okay.
even if there isn't stenosis. Remember, the opening snap happens when those thickened leaflets reach their maximum opening.
It's about the quality of the leaflets.
It is. However, the opening snap in mitral regurgitation is often subtle, and you might only pick it up on an echocardiogram.
So we might not hear it.
Right. If you do hear it, it's crucial to distinguish it from the opening snap of mitral stenosis.
Right.
Remember, the opening snap in mitral stenosis is usually louder
Okay.
and occurs closer to the second heart sound because of that higher pressure in the left atrium forcing the valve open earlier.
Okay.
In mitral regurgitation, the opening snaps softer and happens a bit later.
Subtle, but you can tell them apart.
Exactly. What about that fourth heart sound, S4? So that low-frequency sound just before S1
Right.
occurs when the atrium contracts, pushing blood into a stiff ventricle.
Oh,
It's like a thud.
a thud. What does that tell us with mitral regurgitation?
Interestingly, you won't typically hear an S4 in cases of rheumatic mitral regurgitation.
Oh, interesting.
This is because the left atrium has had time to adjust to that extra volume and isn't having to work hard to push blood into the ventricle. It's relaxed and doing its job.
So no S4 means the atrium is happy.
You got it. But there are exceptions to this.
Okay, like what?
For instance, in acute mitral regurgitation,
Right.
where the onset is sudden,
Okay.
the left atrium hasn't had time to dilate. It has to contract more forcefully.
Got it.
And that's what creates the S4.
So it's putting in overtime.
You got it.
Yeah.
You might also hear an S4 in cases of mitral regurgitation associated with coronary artery disease.
Okay.
The heart muscle itself is damaged and stiff in these cases,
Right.
making it harder for the atrium to push blood into the ventricle.
So S4 is about a stiff ventricle, not an overworked atrium.
That's right. And hypertrophic cardiomyopathy,
Right.
where the heart muscle is abnormally thickened, can also lead to an S4.
Okay.
So the presence of S4 in mitral regurgitation could point to a few different things. An acutely overloaded left atrium or a stiff ventricle, depending on the underlying cause.
So context is everything.
You're absolutely right.
Mm-hmm.
Now let's talk more about that murmur of mitral regurgitation. We know it's a systolic murmur,
Right.
but are there different types associated with mitral regurgitation?
I thought they all sounded the same.
Not necessarily. So the classic mitral regurgitation murmur,
Okay.
it starts with S1
Yeah.
and continues throughout systole,
Okay.
ending at or even after S2.
Got it.
We call this a holosystolic murmur.
Holosystolic murmur.
It sounds like a continuous whooshing because the leaking happens throughout the entire contraction phase of the heartbeat.
Okay, but there are times when it's not holosystolic.
That's right. Think about mitral valve prolapse.
Okay.
The murmur typically starts later in systole
Okay.
and gets louder toward S2.
Okay.
This is because that prolapsing leaflet doesn't start leaking until the ventricle has contracted enough to push the leaflet back.
Oh, so it's a delayed leak.
Exactly. What else can cause a non-holosystolic murmur? Dysfunction of the papillary muscles can also cause a late systolic murmur.
Okay.
These muscles, remember, help control the valve leaflets.
Right.
And if they malfunction, the timing of that leak changes. The
The
murmur in acute mitral regurgitation might start loud and gradually fade.
Okay.
We call this decrescendo.
Why would that be?
It's because of those sudden pressure changes.
Okay.
Imagine that higher pressure in the left atrium forcing those mitral valve leaflets to close early,
Right.
reducing the leak later in systole.
So it shrinks as the pressure balances out.
A good way to think about it. And finally, in cases of mild mitral regurgitation, the murmur might be short and not extend to S2. The length of the murmur can sometimes indicate the severity of the regurgitation.
So shorter means less severe.
It can be an indicator, but remember, it's not a perfect correlation.
Right.
Factors like heart rate body habitus, the presence of other cardiac conditions can all influence the loudness of the murmur.
So it's not a simple equation.
It isn't. Is there a specific type of diastolic murmur associated with mitral regurgitation? Yes, there's a special type called the mitral flow murmur,
Okay.
which sounds like a low-pitched rumbling similar to the murmur of mitral stenosis.
So it can be tricky to tell them apart.
It can be. The cause is different.
Okay.
So with severe mitral regurgitation, the left ventricle becomes dilated and overloaded with blood.
Right.
During diastole, the ventricle rapidly fills,
Okay.
and that large volume of blood rushing through the mitral valve
Right.
creates turbulence and a murmur.
Okay.
It's like the sound of a rushing river filling a wide basin.
So the rapid filling creates the sound.
Exactly. And in this case, the valve itself is normal.
Okay.
It's the sheer volume of blood moving through it that causes the murmur. You often hear an S3 sound along with this mitral flow murmur,
Okay.
adding to the evidence.
So we can use the sounds to tell them apart?
We can, what else helps? The
Yep.
timing. The mitral flow murmur ends well before S1,
Right.
while the murmur of mitral stenosis often extends up to S1.
Got it.
Also, the mitral flow murmur has a lower pitch,
Okay.
a subtler rumble compared to that mitral stenosis murmur.
Okay.
And importantly, the mitral flow murmur is usually a good sign in mitral regurgitation.
Good sign. How so?
It suggests the heart can still handle that extra volume.
That's good to know.
Yeah.
Now, you mentioned earlier that the intensity of the murmur can vary.
Yes. The murmur of mitral regurgitation can change in intensity from beat to beat.
Wow.
This is especially true if the heart rhythm's irregular, like in atrial fibrillation
Okay.
or when there are extra heartbeats. It's all about the amount of blood in the ventricle.
So a more irregular heartbeat makes it more variable.
Precisely. More blood in the ventricle means higher pressure and a louder murmur. It's like squeezing a water balloon.
Okay.
The more water inside, the higher the pressure.
I get it.
And this variation in intensity is actually a distinguishing feature of mitral regurgitation.
Okay.
It helps us differentiate it from other murmurs that don't typically vary as much.
Okay.
From beat to beat, like the murmur of aortic stenosis.
So listening for the variation is another clue.
It is. Now, mitral regurgitation murmurs can sometimes radiate to unusual places like the right armpit or even the pulmonary area.
Why would that be?
It all comes down to the direction of blood flow.
Okay.
Imagine the leak in the mitral valve like a stream of water being redirected by obstacles.
I like that.
Usually the blood leaking back into that left atrium flows towards the back of the heart.
Okay.
That's why we hear the murmur best at the apex
Right.
and radiating towards the armpit.
Got it.
But sometimes the jet of blood takes a different path.
So the direction of the leak influences where we hear it.
Exactly. For example, if the leak is caused by an endocardial cushion defect,
Okay.
a type of congenital heart defect,
Okay.
the murmur might be louder on the right side of the chest.
Oh, interesting.
And if the leak is directed towards the wall separating the two atria,
Okay.
the murmur might be heard in the right armpit.
So depending on the direction, we hear it in different places.
That's right. Does this ever cause confusion with other murmurs?
Yeah, I wonder.
It can if the leak reaches the left atrial appendage,
Okay.
which is a small pouch-like structure extending from the left atrium.
Right.
The murmur might be loudest in the pulmonary area.
Okay.
This is the same area where you'd normally hear the murmur of mitral stenosis.
So the location isn't always clear.
It isn't. You have to consider all the features of the murmur,
Right.
the timing intensity radiation,
Yeah.
as well as other clinical findings.
So you're putting the puzzle pieces together.
Exactly.
So if you hear pansystolic murmur at the apex of the heart in a child, does that always mean mitral regurgitation?
Not necessarily. You always have to consider other possibilities, especially in children.
Okay.
A murmur like that could be due to a congenital heart defect called L-transposition of the great arteries,
L-transposition of the great artery.
where the aorta and pulmonary artery are switched.
That's a big difference.
It is. How can doctors tell those two conditions apart?
Yeah.
Well, when the aorta and pulmonary artery are switched, the blood flow in the heart is completely different.
Right.
In addition to the murmur, you'd likely see other signs.
What kinds of signs?
Strong pulsations in the neck veins, a loud second heart sound,
Okay.
specific patterns in the jugular venous pulse, and a slow heart rate. These all point toward a different diagnosis.
So it's a combination of signs, not just the murmur.
Exactly.
Yep.
Now, how do doctors differentiate between acute and chronic mitral regurgitation?
Okay.
The onset of symptoms is a key difference.
Okay.
Acute mitral regurgitation comes on suddenly,
Right.
causing shortness of breath and pulmonary edema.
Okay.
In chronic mitral regurgitation, the symptoms develop slowly over time as the heart adapts.
So the speed of onset?
Exactly. In chronic mitral regurgitation, the heart has had time to adjust to that leaking valve.
Right.
You'll usually see an enlarged heart on a physical exam or a chest x-ray.
Right.
In acute mitral regurgitation, the heart might not have had time to enlarge.
Got it.
So these signs might be absent. What about the heart sounds?
Okay.
The first heart sound, S1, is usually loud in acute mitral regurgitation because the leaflets are still structurally normal and able to close forcefully.
Oh.
In chronic mitral regurgitation, S1 is often soft, as we talked about earlier. And what about that fourth heart sound, S4?
Okay.
So that's common in acute mitral regurgitation. Remember, it indicates the left atrium is working extra hard
Okay.
to push blood into the ventricle,
Right.
which isn't used to such a high volume.
Okay.
In chronic mitral regurgitation, S4 is usually absent
Okay.
because the left atrium has had time to adapt.
So once again, working overtime.
That's right. The murmur, too, can give us clues.
Okay.
In acute mitral regurgitation, it often starts loud and gradually fades because that increased pressure in the left atrium can force those valve leaflets to close prematurely.
Right.
In chronic mitral regurgitation, the murmur is usually present throughout systole.
Okay, so that whooshing sound.
Yeah. Are there any other key differences?
I'm sure there are.
There are.
Yeah.
So pulmonary hypertension's more likely in chronic mitral regurgitation because the lungs have been exposed to higher pressure for a longer time.
Right.
In acute mitral regurgitation, that might not have had time to develop.
Okay.
So to summarize, it's the speed of onset. Heart size, heart sounds the murmur.
Okay.
And the presence of pulmonary hypertension that help differentiate between acute and chronic mitral regurgitation.
So you're looking at all these different factors.
We are. It's a multifaceted diagnosis.
Now, we talked about that classic whooshing holosystolic murmur of mitral regurgitation.
Right.
But you said that other conditions can also cause similar sounding murmurs.
Yes, that's right. Hypertrophic cardiomyopathy, or HOCM, and mitral valve prolapse, or MVP,
Okay.
can sometimes mimic the murmur of mitral regurgitation.
So how do you tell them apart? They all sound like whooshing.
Yeah, but there are subtle differences in the timing, location, and qualities of the murmurs.
Okay.
So, for example, the murmur of mitral regurgitation is typically present for the whole systolic phase,
Yeah.
that contraction phase of the heart.
Right.
The murmur of MVP is typically late systolic. Okay.
Starting sometime during systole and often growing louder towards S2.
Got it.
And the murmur of HOCM can be variable, but is often mid-systolic,
Okay.
starting after S1 and ending before S2.
So the timing is the first clue.
It is.
Yeah.
What else do you listen for? Location matters too.
Okay.
Mitral regurgitation's best heard at the apex of the heart
Right.
and often radiates towards the armpit.
Okay.
MVP is usually best heard at the apex too, but it might radiate more towards the left sternal border.
Got it.
HOCM is typically best heard along the left sternal border and might radiate to the apex.
Okay.
But not as strongly as in mitral regurgitation.
So even though they're all heard at the apex, the radiation is different.
It is. What about the sound itself?
Okay.
The quality of the murmur is another clue.
Right.
Mitral regurgitation often sounds soft and blowing.
Okay.
The murmur of MVP can be raspier or even musical,
Interesting.
while HOCM is usually harsh and can be quite loud.
Wow. So it's not just where you hear, but what it sounds like.
It isn't.
Yeah.
Anything else doctors consider?
Yeah. The presence of other signs.
Okay.
So for instance, with MVP, you might hear a click along with the murmur.
Look like.
That's the prolapsing leaflet snapping taut.
So a snapping, then a whooshing.
Exactly. With HOCM, you might feel two distinct thumps as the ventricle contracts. We call this a double apical impulse.
Double apical impulse.
And it occurs because the thickened heart muscle contracts in a jerky, uncoordinated way. It's almost like the ventricle is stuttering.
So it's stuttering.
Yeah.
It seems like you need to be a real detective.
You do?
Yeah.
What else helps with the diagnosis? Sometimes position changes or maneuvers can help differentiate between these murmurs.
Okay.
So, for instance, standing up usually softens the mitral regurgitation murmur,
Okay.
but standing often intensifies the MVP murmur
Okay.
because it increases that prolapse of the leaflet.
Got it.
Standing up can either increase or decrease the intensity of the HOCM murmur depending on the patient. The Valsalva maneuver can also help.
Remind me what that is again.
So that's when you forcefully exhale against a closed airway, like when you're lifting something heavy.
Okay.
This maneuver decreases blood flow to the heart
Okay.
and typically softens the mitral regurgitation murmur, intensifies the MVP murmur, and has little effect on the HOCM murmur. The second heart sound S2 can also provide some insights.
Okay.
So
I'm curious.
in HOCM, the order of the two components of S2 is often reversed.
Okay.
We call that paradoxical splitting.
Paradoxical splitting.
This happens because the thickened left ventricle takes longer to eject blood,
Right.
delaying the closure of the aortic valve.
So it's all about the timing.
It is. Are
Right.
there any other clues?
I'm listening.
The fourth heart sound S4.
Okay.
It's often present in HOCM
Okay.
because of that stiff ventricle
Right.
and less common in mitral regurgitation. It's usually absent in MVP.
So when evaluating a murmur, we're thinking about the timing, location, the quality of the sound,
Right.
other associated findings, how the murmur changes with position changes,
Yeah.
the characteristics of S2 and S4. It's like a checklist.
It is. By carefully considering all these clues, doctors can usually differentiate between mitral regurgitation,
Right.
MVP, and HOCM.
Okay.
It's a process of elimination and pattern recognition.
That's amazing. Sounds like a challenge.
It can be. Now let's move on to aortic stenosis,
Okay.
a narrowing of the aortic valve.
Got it.
So what causes this condition? Aortic stenosis has several causes,
Okay.
and where the obstruction occurs is a key piece of information.
Okay.
So we categorize aortic stenosis based on whether the narrowing is above the valve, at the valve itself, or below the valve.
So you're finding the bottleneck.
Exactly, narrowing above the
Yeah,
valve,
right.
called supravalvular aortic stenosis.
Supravalvular aortic stenosis.
It's rare and often present at birth.
Okay.
Narrowing at the valve itself, valvular aortic stenosis.
Okay.
That's the most common type.
Got it.
And narrowing below the subvalvular aortic stenosis
Subvalve.
is often caused by a congenital abnormality called a subaortic membrane. It's like a little curtain partially blocking the exit.
Oh, okay.
So it can be a problem with the valve itself or something blocking it above or below.
Okay.
So let's dive into valvular aortic stenosis a little deeper.
Okay.
Congenital aortic stenosis is often caused by a bicuspid aortic valve,
Okay.
where the valve has 2 leaflets instead of 3.
Right.
This can lead to stenosis either at birth or later in life as the valve becomes calcified. Think of it as a design flaw.
So the valve isn't built right.
Exactly. Rheumatic aortic stenosis, while less common than rheumatic mitral stenosis, can occur after rheumatic fever.
Okay.
The inflammation from the fever can damage the aortic valve,
Right.
leading to thickening and fusion of the leaflets.
So the same problem can affect different valves.
It can. What about aortic stenosis that isn't caused by a congenital issue or rheumatic fever?
Interesting.
There's a wear and tear process that happens as we age
Okay.
called senile degenerative aortic stenosis.
Senile degenerative aortic stenosis.
Calcium deposits build up on the valve leaflets,
Okay.
making them stiff and narrowed. It's like arthritis of the heart valve.
So arthritis of the heart.
Yeah.
Okay, but the heart is a tough organ. How does it manage with this?
The heart's remarkably adaptable.
Right.
So think about lifting weights to build muscle.
Okay.
The heart responds to that increased pressure from aortic stenosis by thickening its walls,
Okay.
particularly in the left ventricle.
Got it.
We call this concentric left ventricular hypertrophy.
Concentric left ventricular hypertrophy.
And it allows the heart to generate the extra force needed to push blood through that narrowed valve.
So it's bulking up.
It is. Are there any downsides to this?
Yeah, I'm wondering.
There are trade-offs.
Okay.
As the ventricle thickens, it also becomes stiffer,
Right.
making it harder for the heart to relax and fill with blood.
Okay.
This can lead to diastolic dysfunction
Right.
and cause symptoms like shortness of breath and fatigue, even if the valve isn't completely blocked.
So it gets stronger but less flexible.
Exactly. I was reading that this process can differ between men and women.
Oh, yeah.
You're right. Women are more likely to develop that concentric hypertrophy without their ventricle getting significantly bigger.
Okay.
This helps preserve their left ventricular function for longer,
Okay.
but they can still develop diastolic dysfunction
Right.
because that heart muscle is stiffer.
Got it.
Men, on the other hand, are more prone to developing eccentric left ventricular hypertrophy, where the ventricle not only thickens but also enlarges.
Yep.
This enlargement increases the stress on the ventricle,
Right.
which can lead to systolic dysfunction, where the ventricle has trouble contracting and pumping effectively.
So men, a bigger, weaker ventricle, women, a smaller, stronger one.
Exactly. Does this affect the course of the disease?
Yeah, that's a good question.
It might. Women often tolerate aortic stenosis better than men in the early stages.
Really?
It's fascinating how these subtle differences in adaptation can impact the long-term consequences.
It is. It's amazing.
And it highlights how important it is to consider gender when managing aortic stenosis.
Absolutely. Now, what happens when aortic stenosis gets really severe? What symptoms do patients experience?
So there's a classic triad of symptoms:
Right.
angina,
Right.
syncope,
Okay.
and heart failure.
Got it.
These symptoms tend to develop gradually as the stenosis worsens and the heart struggles to compensate.
It's a progressive disease?
It can be. Angina or chest pain is often the first symptom,
Okay.
and it's caused by the increased oxygen demand of that enlarged left ventricle.
Right.
The coronary arteries might not be able to keep up.
Got it.
In some cases, the hypertrophy can even compress the coronary artery,
Oh, no.
making the problem worse.
Making it worse.
And of course, some patients might have underlying coronary artery disease as well.
So it's in a perfect storm.
It is. What about syncope?
Okay, so syncope.
Syncope or fainting
Right.
is another common symptom typically occurring during physical activity when the heart's working harder. So because of that obstruction, the amount of blood the heart can pump per minute is limited.
Right.
When your body needs more blood flow, like during exercise, the heart can't keep up.
Got it.
This can cause a drop in blood pressure, leading to syncope.
So it's like pushing a lot of water through a narrow pipe.
Great analogy.
What about heart failure?
That's usually a late manifestation of the disease,
Okay.
developing when the ventricle can no longer compensate for that obstruction.
Okay.
Essentially, the ventricle becomes so overworked it can't keep up. It can't contract forcefully enough, and it can't relax and fill properly.
So it's a double whammy.
Exactly. As heart failure progresses, you see symptoms like shortness of breath, fatigue, and swelling in the legs and ankles.
It's like the heart is saying, help.
Yeah, it is. It's important to remember those three symptoms. Angina, syncope, and heart failure don't always appear in the same order.
Okay.
And some patients might only experience one or two of those symptoms. The clinical presentation can vary. Depending on the severity of this stenosis, the patient, and any other health issues they might have.
So there's no one-size-fits-all.
Exactly.
Now, we talked about the symptoms, but how is aortic stenosis diagnosed? What are doctors looking for?
Well, the evaluation involves a detailed history, a physical exam,
Right.
and often some additional testing
Okay.
to confirm the diagnosis and figure out how severe that blockage is. A key part of the evaluation is determining where that blockage is,
Right.
whether it's above, at, or below the valve.
So pinpointing the location.
Exactly.
Yeah.
Can the physical exam help with that?
Yeah, I'm curious.
It can. If the stenosis is above the valve, the murmur might be louder on the right side of the chest
Oh, yeah.
because the blood flow patterns are different in supravalvular stenosis.
Right.
Feeling the pulse in the neck, the carotid pulse, is also helpful.
How so?
Well, in valvular aortic stenosis, the carotid pulse is weak and has a delayed upstroke because it's harder for blood to get out of the ventricle.
Makes sense.
This helps us differentiate between valvular aortic stenosis and other conditions like hypertrophic cardiomyopathy or HOCM.
How does HOCM differ?
The carotid pulse in HOCM is much more forceful
Okay.
because the obstruction changes throughout systole.
Right.
It's a dynamic obstruction, not a fixed one like in valvular aortic stenosis.
So listening to those heart sounds is really important.
Absolutely. In severe aortic stenosis, the aortic component of the second heart sound A2
Okay.
is often soft or even absent
Wow.
because those thickened valve leaflets don't close properly.
Okay.
The slitting of S2 can also tell us something.
What are we listening for there?
So in mild to moderate aortic stenosis, the splitting of S2 is usually normal.
Okay.
But when the stenosis is severe, that splitting may be narrowed or even paradoxical,
Paradoxical.
where the pulmonary valve closes before the aortic valve.
Interesting.
This happens because that narrowed aortic valve increases the pressure in the left ventricle,
Right.
delaying the closure of the aortic valve.
It's amazing how all these little clues fit together.
It is. What about that fourth heart sound, S4?
Okay.
It's often present in aortic stenosis.
Right.
And it tells us that the left ventricle is stiff
Okay.
and isn't relaxing properly. It's a sign the ventricle is working hard but struggling.
So working overtime, but not efficiently.
That's a good way to put it.
Yeah.
And then, of course, there's the murmur.
The key finding.
Exactly. So the classic murmur of aortic stenosis starts softly, gets louder, and then fades before the second heart sound.
Okay.
We call it a crescendo decrescendo systolic ejection murmur.
Crescendo decrescendo systolic ejection murmur.
It's typically loudest in the aortic area,
Okay.
the second intercostal space to the right of the sternum,
Got it.
and it often radiates to the carotid arteries in the neck.
So traveling upwards?
It is. So the murmur is giving us information about the location
Right.
and the severity of the stenosis.
And makes sense. The later the peak, the more severe.
Yes, exactly, because it means that pressure gradient across the valve is higher,
Okay.
and the sound of the murmur itself can be helpful.
How's?
Aortic stenosis murmurs tend to be rough and harsh, sometimes described as grunting.
Not a pretty sound. What about the Gallavardin phenomenon?
Ah, yes.
Okay.
The Gallavardin phenomenon is when the murmur has a high-pitched, almost musical quality,
Okay.
and is heard best at the apex of the heart.
Interesting.
It can be mistaken for the murmur of mitral regurgitation.
Why does that happen?
It's like an acoustic illusion.
Okay.
It's caused by the turbulence of the blood exiting the narrowed valve,
Right.
creating vibrations in the nearby mitral valve leaflet.
Interesting.
This creates that high-pitched musical sound.
Wow. So one valve problem can create so many different sounds.
It can. Now, are there times when the severity of aortic stenosis might be underestimated?
I'm sure there are.
Yes, there are a few situations where that can happen.
Right.
For example, if aortic stenosis exists alongside other valve issues,
Okay.
like mitral stenosis or pulmonary hypertension,
Right.
those conditions can make the aortic stenosis murmur softer,
Oh, interesting.
masking the severity. It's as if those other valve problems create a traffic jam,
Right.
reducing the flow through the aortic valve. Another situation where it can be tricky is in elderly patients.
Okay. Why is that?
Well, the classic symptoms of aortic stenosis, angina, syncope, and heart failure,
Right.
can be mistaken for other age-related conditions.
Okay.
This can delay the diagnosis.
So it's important to be aware of it.
Absolutely. And high blood pressure or hypertension can make things tricky too.
How so?
Well, hypertension makes the heart work harder,
Right.
which can intensify the murmur of aortic stenosis
Okay.
and lead to an overestimation of its severity.
So it adds extra strain.
Exactly. We need to be mindful of all these factors when evaluating a patient with suspected aortic stenosis. It's about seeing the whole picture,
The whole picture.
not just focusing on a single finding.
Okay, that makes sense. Let's move on to aortic regurgitation.
Okay.
So instead of a narrowing, now we're talking about a leaky aortic valve where blood flows back into the left ventricle during diastole. What are the usual culprits behind this condition?
Well, aortic regurgitation can result from problems with the valve leaflets themselves
Oh.
or from dilation of the aortic root,
Okay.
which is the part of the aorta just above the valve.
Got it.
Think of it this way. If the leaflets are damaged, they can't seal properly, and if the aortic root's dilated,
Okay.
it's like the foundation of the valve is stretched out,
Right.
also preventing a proper seal.
So what kinds of things damage those leaflets?
Things like rheumatic heart disease, endocarditis, and congenital abnormalities like a bicuspid aortic valve
Right.
can all affect those leaflets.
So similar causes to aortic stenosis.
Yeah, just with different effects on the valve.
Okay, so for example, with rheumatic heart disease,
Yeah,
the inflammation scars the leaflets,
exactly.
making them thick, short, and retracted,
It does. They just can't close properly.
so they can't close.
And endocarditis, remember,
Right.
is an infection that can damage the leaflets,
Okay.
creating holes or growths that interfere with their function.
So they can't work.
Right. Bicuspid aortic valves are more prone to leaking because of that abnormal structure.
So many things can go wrong. What about dilation of the aortic root? What causes that?
High blood pressure is a common cause.
Okay.
Also, Marfan syndrome, a connective tissue disorder
Oh,
that weakens the walls of the aorta,
right.
and syphilis, a bacterial infection that can damage the aorta.
So many different causes.
There are.
Yeah.
So that support structure for the valve is weakened or stretched, and it can't close properly.
Right. And we also see aortic regurgitation in cases of trauma,
Yes.
dissection of the aorta,
Right.
and certain inflammatory conditions like Takayasu's arteritis.
Exactly. It's incredible how many different things can lead to a leaky aortic valve.
It is. And
Aren't we-
thankfully, we have echocardiography,
Yes.
which allows us to visualize the valve and the aorta
Right.
to help us figure out the cause.
Exactly. Now, you mentioned earlier the heart's really good at compensating for problems.
Yes.
How does it adapt to aortic regurgitation? Well, the heart's main way of coping with aortic regurgitation is to enlarge that left ventricle.
Okay.
As blood leaks back into the ventricle, it needs to accommodate that extra volume. It's like a balloon expanding to hold more air.
So making more space.
Yes. This enlargement allows the ventricle to maintain a relatively normal ejection fraction,
Right.
which means it's still pumping out a good percentage of the blood it contains,
Right.
even though it's getting more than usual.
So working harder, but still managing.
Yeah.
But are there any long-term consequences to this?
Unfortunately, over time, this chronic volume overload can damage the heart muscle.
Oh, no.
As the ventricle stretches, it has to work harder to generate the same amount of force.
Oh.
It's like stretching a rubber band too far.
Right.
Eventually, it loses its elasticity and snaps.
Wow. So it's working harder, but getting weaker.
Exactly. What happens then? Eventually, this can lead to left ventricular dysfunction.
Right.
The ventricle can't pump as effectively,
Okay.
and the regurgitation can worsen. It's a vicious cycle.
So catching it early is key.
Absolutely. Now, how do the symptoms and signs of aortic regurgitation differ from aortic stenosis?
Right.
What do doctors look for?
Yeah, that's a good question.
Well, the presentation of aortic regurgitation can vary greatly depending on how severe it is, how quickly it developed, and the individual patient.
Of course.
Some patients might not have any symptoms for years, while others may develop symptoms early on.
So it can be silent.
It can. Unfortunately, sometimes by the time symptoms appear, the regurgitation is already severe,
Oh, wow.
and the heart is struggling to function.
That's scary. What symptoms might patients experience?
Well, fatigue is common,
Okay.
as well as shortness of breath and palpitations.
Makes sense.
The fatigue is because of decreased cardiac output. The body isn't getting enough oxygen-rich blood.
So it's not delivering.
Exactly. What about the shortness of breath? That's caused by the blood backing up into the left atrium and lungs, leading to congestion and fluid buildup.
So similar to mitral stenosis, just a different valve.
Exactly. And those palpitations, the awareness of the heartbeat, are often due to the forceful contractions of that enlarged left ventricle.
Okay.
Some patients also experience angina, especially at night or during exertion.
Interesting.
Yeah.
Why would someone with aortic regurgitation experience angina?
There are a few reasons.
Okay.
The enlarged left ventricle demands more oxygen,
Right.
but it might not get enough.
Okay.
Also, the diastolic blood pressure in the aorta can be lower,
Right.
reducing blood flow to the coronary arteries that supply the heart muscle itself.
Right.
And as we talked about before, some patients might have underlying coronary artery disease.
Okay. So a lot to contend with.
What about the physical exam? What clues point to aortic regurgitation?
I'm listening.
A key finding is a wide pulse pressure.
Okay.
The difference between the systolic and diastolic blood pressures?
Right.
In aortic regurgitation, the systolic pressure is often high because of that large volume of blood being pumped out.
Okay.
But the diastolic pressure is low because of the leak.
So high peak, low valley.
That's a great way to put it. We can detect this wide pulse pressure by measuring the blood pressure
Right.
and by feeling the pulses.
Okay.
Aortic regurgitation also has several peripheral signs related to that larger stroke volume,
Okay.
the amount of blood ejected with each heartbeat,
Got it.
and that rapid runoff of blood from the aorta.
So the blood is really surging.
It is, and this can lead to some noticeable signs. For example, the Corrigan pulse,
Okay.
also known as a water hammer pulse.
Water hammer pulse.
It's a bounding, forceful pulse that collapses quickly
Okay.
because of that blood flowing back into the ventricle.
Like a wave crashing and receding.
Exactly. What other signs might be present? We have de Rosiers' sign, which is a murmur heard over the femoral artery in the leg when it's compressed.
Interesting.
And Hill's sign,
Okay.
where the systolic blood pressure is higher in the leg than in the arm.
So the force is more noticeable in the legs.
Right. We might even see visible signs like head bobbing with each heartbeat. And we can sometimes see the blanching and flushing of the fingernails with each heartbeat,
Okay.
called capillary pulsations.
So many different signs. What about the heart itself?
The apical impulse is often shifted downward and to the left.
Okay.
Because of that enlarged ventricle. We might also feel a systolic thrill over the area of the chest overlying the heart.
So the heart's taking up more space.
Exactly.
Yeah,
Listening to the heart sounds is also key.
of course.
The first heart sound, S1,
Okay.
might be soft or normal.
Got it.
The second heart sound, S2, may be split.
Okay.
And you might hear an S3,
Right.
that low-pitched sound indicating rapid ventricular filling.
Okay.
And then there's the murmur.
The defining feature.
It is. So the murmur of aortic regurgitation is a high-pitched, blowing diastolic murmur,
Okay.
heard best along the left sternal border.
Got it.
It usually starts right after the aortic valve closes,
Okay.
and its duration and intensity tell us how severe the regurgitation is.
So it's a wishing after the second sound.
Exactly. And depending on which way that blood's flowing, it might radiate to the apex of the heart or to the right sternal border.
Now, I remember reading about the Austin Flint murmur.
Ah, yes.
Okay.
The Austin Flint murmur is interesting. It's a low-pitched, rumbling diastolic murmur heard at the apex of the heart.
Okay.
But it sounds like the murmur of mitral stenosis.
So confusing.
It can be.
Why does that happen?
Well, we think it's caused by that leaking blood from the aortic valve hitting the anterior mitral valve leaflet,
Okay.
creating a sort of functional mitral stenosis.
So it's creating a blockage.
That's a great way to think about it. And the presence of an Austin Flint murmur usually means the aortic regurgitation is severe.
Wow. So we've covered mitral stenosis, mitral regurgitation, aortic stenosis, and aortic regurgitation. But what happens if someone has more than one valve problem?
Multiple valve problems or multivalvular disease definitely adds another layer of complexity.
I bet.
The presence of one valve problem can affect the blood flow patterns of other valves.
Right.
It can be tricky to figure out how severe each individual problem is.
It's like a puzzle where the pieces are moving.
That's a great way to put it.
Right.
So for example, if someone has both mitral stenosis and aortic regurgitation,
Okay.
the mitral stenosis might make the aortic regurgitation seem less severe than it actually is.
Interesting.
This is because the mitral stenosis reduces the amount of blood flowing to the left ventricle,
Right.
which in turn reduces the amount of blood leaking back through the aortic valve.
So one problem masks the other.
Exactly.
Okay.
Are there any other examples?
I'm sure.
Of course.
Yeah.
Think about the opposite scenario.
Yeah.
The aortic regurgitation can make the symptoms of mitral stenosis worse, even if the mitral valve isn't severely narrowed.
Interesting.
This happens because the aortic regurgitation makes the left ventricle work harder,
Right.
which can worsen those symptoms of mitral stenosis.
So a domino effect.
Exactly. And this interplay makes it really hard to use the standard formulas and techniques we normally rely on
Okay.
to assess individual valve problems.
So it's more of an art than a science.
You could say that we need a thorough history, a detailed physical exam and careful interpretation of the echocardiogram to assess the severity of each valve problem accurately.
It's like detective work.
You're exactly right.
Yeah.
And it often requires a team of experts,
Okay.
cardiologists, cardiac surgeons, and other specialists to develop a personalized treatment plan for each patient.
So teamwork is key.
Absolutely.
This has been an incredible deep dive into the world of valvular heart disease. I feel like I've learned so much.
It's been my pleasure exploring this fascinating topic with you.
And a huge thanks again to London Heartbeat's Z Academy for providing the amazing material for this deep dive.
They're a fantastic resource.
Remember to subscribe to London Heartbeat Z Academy on Facebook, Instagram, Spotify, and YouTube to keep your cardiology knowledge up to date.
Absolutely.
And don't miss out on any future discussions like this one.
You won't regret it.
Thanks for joining us on this deep dive into valvular heart disease. Until next time, keep those hearts healthy and those minds curious.